Well, thank you very much for the invitation to speak and to visit your beautiful city here in Krakow. It's been wonderful so far. I'm going to talk about whether every transplant-eligible patient needs a transplant and will benefit from a transplant in 2022. I'm Kwee Yong. I work at University College London in the UK. And let me advance the slides. Here are my disclosures. Let's check that the pointer works. There we are. So these are the Asmo Guidelines that were published by Tanos Dimopoulos last year. And you can see that if you're eligible for ASCT, the recommendation is a choice of induction regimens, and then everybody gets a stem cell transplant. And the reason we question this today is obvious to everybody. It's because of the acute toxicity. We're familiar with grade 4 infections, ITU admission, GI toxicity. It's my impression that melphalan mucositis, if anything, is worse these days, not better. There is a small mortality risk. The long-term toxicity, secondary primary malignancies, this is a signal which doesn't go away. Hematological malignancies, particular, the risk of mutagenesis, and we've recently had some nice data on the mutagenic effect of high-dose melphalan. Late infections do affect a small number of patients, and of course, quality of life, impact on quality of life. So balanced against that are, of course, increasingly effective induction regimens today, and it's true to say that probably the goalpost changes all the time, but let's look and see what evidence we have. So here I've tried to summarize onto one slide, and this is adapted from that very nice talk by Roberto Mina at EHA, the different randomized studies that we have evidence from today. So starting on the left, you will see here LEN-based chemotherapy as the comparator to ASCT. This was a study by the Italian group published by Francesca Guy a few years ago. In the middle is where the comparator are PI-based chemotherapy, so the EMN study where ASCT was pitched against VMP. Our own Cardamom study I will tell you about, where we compared ASCT to KCD, so these are PI induction regimens. But of course, the standard of care today is probably VRD, and here you have the two sister studies already described very nicely by David Visoli, the IFM, and the Determination study, and of course, the Forte study with KRD. So let's start. I'll go through some of the data quite quickly and just talk about the top-line results. So here is the Italian study where high-dose melphalan was randomized against len chemo, and you can see that here on the left-hand side in progression-free as well as overall survival, there is a benefit for the ASCT arm with the curve separating very nicely for PFS and also here overall survival with a good p-value. And what about the bortezomib-based chemo as a comparator to ASCT, either 1 or 2. This is the EMN study, HOVON study you'll be very familiar with. And here you see progression-free survival on the left, overall survival on the right, and once again, a benefit of the ASCT arm, both in PFS and in OS. Here the hazard ratio is 0.2, but the curves, interestingly, separate very gradually and continue to diverge with a nice long follow-up. But before I go on to talk about some of the other studies, let's step back and think about how the benefit of frontline ASCT actually depends on a very long list of factors. It depends on the induction regimen you choose, it depends whether you use a triplet or quadruplet, and how many cycles. Also, importantly and very importantly, on what you use post-transplant, and whether the agent you use post-transplant interacts with high-dose melphalan. We've talked a little bit about immunological function in the bone marrow. What is the length of maintenance? And I think David Visoli has already referred to the different lengths of maintenance between the IFM and the Determination study. Very importantly, what are the alternatives? If you were to defer frontline ASCT, do you have an effective chemotherapy regimen? And just as important, what are the salvage options for the non-transplant arm. So with that in mind, let's start by having a look at the studies where the comparator was one of our gold standard induction regimen, VRD, and where the trials show the effect of altering and changing the length of maintenance. And here, of course, you've seen this data already. Here's the IFM study and the determination study. Same study design, just a difference in the maintenance duration. In the IFM, it's 1 year. In the determination, until progression. And you see, really, the curves are very similar. They separate very nicely after transplant, and they continue to be separate, but really they run parallel. The difference really is in the numbers. So as you've already heard, in the IFM study, the PFS is 47 versus 35 for the non-transplant arm, and in the determination study, 68 versus 46. But look at this next slide. There is no difference in overall survival, at least not yet, but this is nice long follow-up. I think it's 89 months here and nearly 6 years, 5 years here. And that is despite the fact that in the two studies, a very different proportion of relapse patients in the non-transplant arm went on to salvage ASCT. So in the IFM study, 77% of patients who relapsed in the chemo arm received a salvage ASCT, compared to only 28% of relapse patients in the RVD arm. This is interesting. What it tells you, possibly, is that actually a good number of patients don't actually need a transplant, because when they were randomized to the chemo arm and they relapsed, they didn't actually get a transplant, but the overall survival is the same. But the devil's in the detail. So instead of looking at the structure and the design of studies, the regimens you use, you actually focus down on patient factors. And those are, again, a very long list. You could look at patient characteristics, comorbidities, fitness and frailty, importantly, preference and priorities. Perhaps you have somebody who's age 67, and in the UK, we transplant patients well into their early 70s. Perhaps if they are older, it is their one chance of getting a transplant. That might influence your decision. Disease features are very important. We'll have a look at risk if we have time. But response to induction, and this has already been spoken about very eloquently by David Visoli, about MRD negativity and how perhaps if you're MRD negative, you might be able to defer frontline transplant. So we'll look at this in more detail. Here you see the data from the Forte study, already described to you very nicely, where patients are randomized to one of three arms: KRD with a transplant, KRD without a transplant, and KCD with a transplant. And the winner is KRD with a transplant. And like all these studies, randomized studies in frontline treatment, the superior arm is the arm that gives you a higher rate of MRD negativity. And you've already seen this, that if you compare KRD plus ASCT versus KRD without ASCT, the MRD negativity rate is just over 50%, just prior to maintenance, looks the same. But if you look at 12 months post-maintenance, after 12 months of maintenance, there emerges a significant difference. This tells us something very interesting about the transplant. So either these patients who are MRD negative following the transplant actually had a deeper level of MRD negativity, which they sustained better, or there is an immunological interaction between LEN maintenance, or KR maintenance, and the transplant itself. These are those interesting questions that one continues to explore. What is the role of MRD? Well, high rates associate with longer PFS. We all know that. Generally, you see this in the ASCT arm, and that is why the outcomes are superior. Sustained MRD negativity is key. And of course, in order to sustain it, you need effective consolidation, and maintenance strategies. But what no trial has informed us so far is whether MRD status can inform us with regard to the benefit of ASCT. What about patients who are MRD negative post-induction? Do they need an ASCT? Now, the MIDAS study from the IFM is trying to answer this question. But let's have a look at this data you've seen already. So this was shown by Paul Richardson at the IMS meeting in LA. And you've seen this data, which is that for the limited number of patients in whom there was data for MRD. Now, this is MRD taken after ASCT or consolidation. So all the studies have shown you MRD just before maintenance. And what it shows you here is that if you're MRD negative after transplant or chemotherapy consolidation, it doesn't really matter which arm, that there's no difference between patients in randomized arms. But if you remain MRD positive after ASCT or consolidation, you seem to do better after ASCT. I think these data relate to the different depths of MRD negative, of MRD or residual disease, but the interest is in these curves. So what about patients who are MRD negative post-induction? So to answer this question, perhaps I could show you a bit of data from the Cardamom study. The Cardamom was a phase 2 study, smaller than the studies we've talked about. We only had 281 patients who received KCD. So this is a PI-based chemotherapy design, 56, so higher dose than most studies, frontline, bi-weekly K with cyclophosphamide and dexamethasone, and they were only randomized after they had a successful harvest and achieved a PR to a transplant of 4 further cycles of KCD, and then maintenance for 18 cycles. And the primary endpoints were VGPR to a KCD and PFS at 2 years. But we measured MRD after induction and then pre-maintenance and after 6 months of maintenance. Our study was designed differently. It was designed as a non-inferiority design. So we asked the question, are patients harmed by not receiving a transplant? And here you see in a nutshell the data. On the left-hand side for patients who are MRD negative, on the right-hand side for patients who are MRD positive. But the MRD was measured after induction. You see for patients who are MRD negative, there was no difference in the PFS between the ASCT and the consolidation lines. Now, because the PFS curves cross, my statistician tells me that we have to talk about the restricted mean survival time, which is why this funny acronym comes up, RMST. But if you look at patients who are MRD positive, there is a significant difference in the PFS between the ASCT and the consolidation arm. This is just a phase 2 study. It's a post hoc analysis and remains to be confirmed in studies to come. What about cytogenetic risk? So here we have some data from the determination study to inform us. On the left, high risk, and the right, standard risk patients. There we go, here's the data. And you can see that for both high risk and standard risk patients, there is a significant benefit in the ASCT arm. However, the margin of benefit seems to be greater for the high risk patients. And interestingly, they separate very rapidly at the start, and then the curves are parallel, unlike for standard risk patients. So for high risk patients, the PFS with the ASCT arm is 55 months versus 17, whereas in standard patients, there still is a notable difference between 82 and 53, but it's of a smaller magnitude. I'm coming to the last few slides now. If instead of replacing ASCT with chemotherapy, we think about whether we might replace it with immunotherapy, with one of the bispecifics, or with a CAR T therapy, those days may not be so far away. Here is a scheme of the CARTITUDE-6 study, which is run through the EMN, and many of you might be familiar with this, where patients receive DVRD induction, and then either an ASCT or cilta-cel, which is one of the licensed BCMA CAR-T studies, and then limited Revlimid maintenance, len maintenance for 2 years. So the whole point of achieving sustained MRD negativity is to be able to stop treatment, as you've heard already. There's no point talking about cure if you have to continue treating patients. So in summary, upfront ASCT prolongs PFS1 as compared with triplets, our current standard of care triplets, but there doesn't seem to be an OS advantage. The PFS1 advantage may be greater in some subgroups, perhaps high-risk genetics. But selected subgroups perhaps may be allocated safely a deferred ASCT, or perhaps no ASCT. These might be people who are MRD negative after induction. And a large PFS1 benefit, like in the determination study with no OS difference, must mean that survival after relapse is poorer in the ASCT arm. So if you have upfront ASCT, there might be a price to pay later on. And of course, we have prospective studies to clarify which patients' upfront ASCT remains of benefit. The next slide is, I think, the MIDAS study, which we've already seen. So I think it's really important to do prospective randomized studies. We don't know that stopping treatment just because somebody has sustained MRD negativity is the right thing to do. And a randomized study like this may be where we will get the answer. Thank you for your attention.
Thank you, Professor, for a very interesting lecture. It's time for discussion and questions. Any from the audience? Professor Chowiecki.
Thank you for this lecture and review you just gave us. My question concerns planned tandem autologous transplant. You skipped this topic. Yes. Why?
Thank you. That's a very good question. I'm aware that that a tandem transplant has been shown to be of benefit in the EMN study, particularly in patients with high-risk disease. I think it's a good and fair question as to whether a tandem transplant has additional benefit over a single transplant. I think for the interest of time today, I wanted to focus on how we could safely defer transplant in patients, not add another transplant. But if I were to ask to comment on the possible benefit of a tandem transplant, I think once again this is a moving feast. There undoubtedly will be a group of patients who will benefit from a tandem transplant. They may be patients who perhaps had not achieved the maximum benefit from their induction regimen. They may be patients who are particularly sensitive to alkylator therapy, like the 1114s who are quite refractory at the beginning. But they also have to be patients who can sustain the disease response between one and the second transplant. What we find trying to deliver tandem transplantation in the real world is that patients relapse between the two, and that you really have to have fit patients who can go straight on to the second transplant in a very short space of time. But it's a great question. Thank you.
May I ask you, you mentioned in your one slide that there is an option of deferred transplantation, especially in MRD negative patients, right? But do we have the data, really, that this approach that you do delayed transplantation really helps the patient? Because the question is also somehow related to the fact that we collect cells as a beginning for 2 transplants usually. We do even transplantation first, the patient responds well, and we keep these cells, and we think that if the relapse happens, then we can do a second transplant. So my question is related to those two situations.
Yes.
First, really, do we have the data that the second transplant in patients who already received transplantation gives any benefit? And the second question is whether the patient, let's say, who are MRD negative, we defer the transplantation. Do we think, or do we have the data showing that doing the transplantation later on really helps these patients?
Thank you. So the first question is about salvage transplantation. The main trial I would refer you to is probably Gordon Cook's Myeloma 10 study. I know that was performed quite a few years ago when he compared a salvage ASCT with melphalan 200 against cyclophosphamide weekly, and cyclophosphamide weekly may not be such a strong comparator. I think once again, the way to answer that question is to look at the real-world situation about what alternatives are available. So I think in an economic and in a situation where resources are not limited and there are good salvage options available, I suspect that a salvage transplant is not going to be too popular. But there are many parts in the world where a salvage transplant would seem to be would be the best option because they don't have access to extended regimens, for example, CD38 regimens. For the second transplant, it's a very good point. So we collect enough stem cells for 2 transplants, and then we defer the transplant for MRD negativity, and it's a bit of a waste. Yes, it's a good point. I suspect that, I don't know, but I suspect that with the use of CD38 antibodies in frontline induction regimens, it won't be so easy to collect 2 transplants. We are finding the same ourselves, particularly moving to GCSF mobilization with the COVID pandemic. So it may be that the desire and the impetus to collect enough for 2 transplants will slowly fade away as alternatives come in, particularly our new immunotherapies. But again, you have to look at the real-world situation where you are.
Tandem. The other one is what patient ask for. It's collect my cells when I am in good remission and
Yes.
make me the first transplant. If I need, you can make the second
Yes.
one. So the problem is regulations from the insurance side, for example. I know that in the United States, patients frequently ask for it, and probably they are empowered to get such strategy. It's not the case in our country, I mean in Poland. But we collect for each patient enough cells for 2 transplants, and we do tandem transplant within a phase 2 study plan, one with high MEL conditioning, the second one with total marrow irradiation as conditioning. Oh. These are 2 completely different approaches, and we believe that the results will be better when using these 2 techniques. Until now, I can't give the current results, but Dr. Kruszelnicka who is here in this room, she can answer the preliminary results. Another problem, I think, is whether in one of your slides you did show that the MRD before the transplant didn't correlate to the long-term result, which is surprising, at least for me. So how do you explain it?
I'm not sure. To your first point, I absolutely agree. I think that it's a fascinating study to compare 2 different forms of conditioning for your tandem transplant. With the MRD, I didn't show the data comparing MRD negative post-induction versus MRD positive post-induction, but there's a clear difference. So if you're MRD negative post-induction, you do better than if you're MRD positive. What I tried to show is that if you're MRD negative, there is no benefit from the transplant. But if you're MRD positive, it looks as if there is a benefit. But there is a difference between the MRD negative and the positive.
I think is that the timing of all procedures included in autologous transplantation is extremely important.
Yes.
We qualify as the patients, and after some days or weeks pass before mobilization, then between mobilization and transplantation again, second transplant, and so. It's not easy to do it in right time, but when interpreting the surprising results, we should take it into consideration.
Absolutely.
Extremely heterogeneous material at the end, at the transplant.
Thank you. I agree. Thank you.
I have a question regarding, because for last 40 years we are doing transplantation. It's our routine practice. And what do you think regarding mobilization and conditioning? It's in Poland for many years, for last, I think, 10 years, we are using RSC to collect stem cells and GCSF. Before we use cyclophosphamide, sometimes we use etoposide. It's not, I know that in many countries they are using cyclophosphamide. How is in UK? And regarding conditioning, of course, we use MEL 200, but Spanish data, we have busulfan and Bumel. It's much better. What do you think about this?
Yes. Thank you. I'll start with the mobilization. In the UK, it's standard. We use standard cyclophosphamide 1.5 gram per meter squared. However, during the pandemic, because of the increased hospitalization and the number of days on the machines and a risk of infection, we went over to GCSF. But we realized after a while that we were using more plerixafor and we had some failures.
It was successful because in our department, after GCSF, it's
not so it's not so successful if you want to collect enough for 2 transplants, and particularly if we're using Dara-VCD as induction, we've noticed that difference with the CD38 antibody. So we're trying to go back to cyclophosphamide. I have no experience with the other mobilization regimens, except that if a patient has not made a deep enough response, then we mobilize with ESHAP or with DT-PACE, which will have etoposide and RSC, and that gives more cytoreduction. So that is our policy. And the conditioning, in the UK, we are very traditional. We still use melphalan 200. But I think the Spanish data are very interesting, and I suspect that's telling us that there's a group of patients for whom additional conditioning would be important, and perhaps they are probably patients with disease that is sensitive to traditional cytotoxic chemotherapy. But we have to find the right patients, and we have to get the balance with toxicity, because there is a toxicity signal.
So what you said, you don't changing your policy in routine practice based on the results you showed to us in terms of the need for transplantation. Every eligible patient in the UK or at your center receives transplantation now, or do you tailor, do you use your knowledge to somehow decide or to discuss with the patient? Having said also about the mortality, late effects, right?
That is true. In the UK, it is still standard practice to offer upfront stem cell transplantation to transplant-eligible patients. In the UK, things move slowly. And so we're still very much standard of care, stem cell transplantation. However, there are studies coming along, and when the Cardamom study matures and reads out, we hope to have a more personalized, risk-stratified approach. But there are some patients, particularly in the private sector, who ask to defer transplant, and I let them. Yeah.
What is your opinion about allogenic stem cell transplantation in multiple myeloma? Your opinion?
Yes, we carried out a reduced intensity transplant program with Steve McKinnon back in the 2000s upfront, and the results were not very encouraging. So I think reduced intensity transplantation in multiple myeloma, even with following on tandem with an autograft, is very difficult to carry out in order to demonstrate that it has benefit. And if you cannot demonstrate that it has benefit, you cannot change practice. However, we do have a group of very young patients for whom, particularly if they have a sibling match, that we put them forward for a reduced intensity tandem autograft. And we have a small collection of patients who have done very, very well. They may have had bad GVHD, but they are alive and disease-free. But that is not in the context of a clinical trial, and I suspect that the day has passed for doing a good clinical trial in this area. Maybe it's a shame, but the world moves on.
Too many medicines, new. Professor Hołowiecki.
There are two possibilities. One is to use allogenic transplant in heavily pretreated and relapsing patient. And the second, to do it as a planned allo approach. And this is addressed for younger people with high risk, molecular high risk. So I'm not a skeptic for allogenic transplantation. If you did it with RIC in patients who are MRD positive, so it doesn't make sense at all. In such patients, you should make tandem, auto-allo. We are running such a program, again, 34 patients were done until now, and it works quite fine. So as I remember, in the preliminary analysis of our allo program, we have at 2 years, 94% patients alive, yes, overall survival, and 84 or so disease-free survival. It depends how you do it.
Yes.
Thank you.
Yes, thank you. Congratulations. I suspect that small studies like those are likely to yield very encouraging results. The problem is being able to translate it out to change standard of care, because it is so individualized to the center and the supportive care and the experience of the team.